talked to her about it because in the past we haven't been able to participate. I told her, you know, this is how we can't fly a lot of times. So we'll get her here.
Hi, David.
Great.
We are connected. That was a great guy.
Wait a minute.
swimming buddies who had needs. And one of them today told me, she said, jump in there. Actually, this little thing. So she said, all of a sudden, just
All right. Well, good evening and welcome. For those of you who don't know me, I'm Sue Landgraf. I'm the Executive Director of CFRI, Cystic Fibrosis Research Incorporated, and I would like to welcome you to tonight's CF Discovery Series. For all of those of you who are here, fabulous. We also have an online audience. We're very glad that they can join us. Tonight's presentation is our first of 2014, and it is 5 years of CF newborn screening. And we have a very special guest tonight, Dr. Jacquelyn Zirbes. She's a doctor of nursing practice, and she is also an RN, a CNP, and a CCRC, and she will have to explain to all of you what all of that means. But she is a very important person, and we're delighted that she can be here tonight to join us to update us on what's been happening in the last 5 years. Jackie is the CF Newborn Screening Coordinator for the Cystic Fibrosis Center at Stanford. And as an important aside, she also helped develop the newborn screening program in the state of California. Jackie provides direct clinical care to infants diagnosed with CF through the newborn screening program before transferring their care to a pediatric pulmonologist. Dr. Zirbes is also the pediatric lung and heart-lung transplant coordinator at Stanford. She will share the diverse lessons learned since the implementation of California's CF newborn screening program, including the latest data and new strategies for early intervention. So before we begin tonight's program, as usual, I would like to thank two very special people, Carol Jenkins, who is our retired ED at CFRI, and Camille Wasowich, who is a nurse practitioner at the Stanford CF Adult Clinic. They collaboratively created the CF Discovery Series, so we have them to thank for tonight's presentation. Our Discovery Series was designed to make CF information accessible to the CF community by presenting various speakers that are experts in their fields, such as Dr. Zirbes. We have 6 presentations a year, 3 in the spring and 3 in the fall. Now, before beginning tonight's presentation, I would like to note that no information presented tonight is intended for a patient's diagnosis or treatment. And as always, we urge you to work together with your healthcare team for your medical treatment. A special thank you to Genentech, Cornerstone Therapeutics, and CF Services Pharmacy for supporting tonight's program. They have generously underwritten tonight's expenses, and I would like to welcome Marissa Rapport with Genentech and Cesar Castillan with CF Services Pharmacy. So let's give them a hearty welcome. Thank you very, very much. We could not do this without you, so we really appreciate everybody's support. Tonight's program, live from the Crown Plaza Cabana Hotel in Palo Alto, is being produced by your CFR Live team, Eric Martin, who is not here tonight, Scott Wakefield, and David Suhu, and Mary Convento will be fielding the online questions from our audience at home. I encourage all of you to ask questions, whether you are here or whether you're at home online, and to those of you who cannot join us in person tonight and would like to ask questions, you will need to sign in through Ustream. And now, for the moment you've been waiting for. Newborn screening for CF is now 5 years old. With the help of advocacy work by CFRI and so many others, we were successful in passing legislation to add CF to the core screening panel for newborn screening. Newborn screening for CF enables those infants to get an immediate start on therapy, something that never existed before. On a personal note, My 29-year-old daughter did not have the benefit of CF newborn screening and wasn't diagnosed until 22 months old. Just think, for those 22 months, she could have been receiving some medical intervention. So I'm very grateful for what has happened in the past 5 years. But now the question is, what are the outcomes after 5 years? So let me have Jackie Zirbes come up and update you on the CF newborn screening over the past 5 years. And she will take your questions at the end of her presentation, but please join me in welcoming Jackie Zirbes.
Thank you. And Siri, this is my list that was given to me for this evening that I'm supposed to be talking about. I'd like to begin with an overview of cystic fibrosis newborn screening, and then talk specifically about the California screening program, the demographics of CF, and the care of infants identified through newborn screening, and the recommendations from the CFF and what we're implementing at Stanford. I've been given the task of talking about the difficult subject of CRMS. I would also like to talk about the SWEAT study that we're doing at Stanford, and leave time for questions and discussions. So what is newborn screening? First of all, it is a nationwide program that has been developed to define infants in the newborn period that will have certain health conditions. And it's in order to begin treatment early to prevent serious lifelong problems. This slide here depicts a picture of a Guthrie card with the newborn screening blood spots that are obtained when an infant is born. And this happens in every state. In California, we screen for over 50 disorders, and the key is pre-symptomatic diagnosis. The newborn screening programs do vary from state to state, and as we discussed, we added newborn screening with cystic fibrosis in 2007. Texas and Connecticut were slow. They added in 2009 and 2010. I'd like to just emphasize screening is not diagnosis. The screening procedure itself does not diagnose illness. Those who test positive on the newborn screen are sent for further evaluation for subsequent diagnostic testing or procedures to determine whether in fact they do in fact have the disease. The program in California was established after years of some exploratory studies looking at the diversity of the genetics in the California population. Our program in California uses both IRT and genetic analysis. We detect both severe mutations as well as novel variants in our screening program. Excuse me, we have a 4-step process in our state. Now, not all states use this process. What we do is the first step blood spot is checked for something called immunoreactive trypsinogen, or IRT. If it is above the cutoff of 67, that spot is then sent for a 40-panel CFTR mutation analysis. If 2 mutations are found, the patient is immediately referred to a CF center. If only 1 mutation is found, that specimen then goes for further sequencing at a Stanford University lab. And that happens throughout the state of California, so other sites are sending their specimens to Stanford for processing. A patient is referred to a CF center when there are 2 mutations identified. This slide here shows a little bit of the algorithm process that we go through. The cutoff I mentioned is 67 nanograms per mil, which is the 98.4 percentile. You can see here on step 1, the IRT. If the IRT is not above 67, the patient is considered screen negative and you don't hear from us. And then if you further follow on down, the high IRT, there is the 2 CF mutations, then they're referred to the CF center, and then the process further down there. I think this is right down here. If only 1 mutation is identified in this process, the person is identified as a carrier and they're referred from the state to a genetic counseling. That is usually obtained over the phone, although some insurances will pay for patients to actually come and have a full genetic counselor consult. And then we, at the CF centers, are seeing patients that end up right here. Some people wonder, well, why can you have an IRT besides CF? The IRT is secreted by the pancreas, and it's normally found in everyone in small amounts. newborns will have an increased IRT in individuals with CF. Patients that are, or gene carriers with one mutation will also have an elevated IRT, but sometimes not as high as someone with CF. There are a number of other reasons why there may be a high IRT, and hence why they're not referred to the CF center once the sequencing is performed. And it may be because of prematurity, a stressful delivery, sometimes infection. We will occasionally get calls in our program for questions about IRT, but we don't see those patients unless the pediatrician is concerned about the baby's health. Some of the challenges that we face in this program are, for the diagnostic guidelines call for an elevated sweat test, which is above 60. And in California, we're already seeing patients referred to our sites with 2 genetic mutations identified. Sometimes we'll see individuals where the sweat chloride is outside the diagnostic range. And it really creates an uncertainty between the genotype and the phenotype. And it's a dilemma not only for us as clinicians, but as well as the families. When we started out the newborn screening program, the mutations right here were what we started out with. These mutations were then further added, and then in 2008, these were added. So now we have the 40 panel. This pie chart is compliments of my colleague at the Department of Health. The slide shows such a wide variety of CF mutations here that are identified in the state of California. As of 2010, there have been 474 cases of CF identified, and out of them, only 28%, or 134, carry 2 copies of the Delta F, with 40% only having 1 copy of the Delta F mutation, and 24.7%, or 117, have other variants identified. So what do we miss? What are we missing in this group of patients? Well, as of June 30th, 2013, we have identified 33 missed cases. And the reason why some of these cases were missed, 18 individuals were missed in step 1. Their IRT just was not above the cutoff value, so they were never referred. There were 11 individuals where there were just no mutations on the panel. Some of these cases, they may have had 2 mutations. They may be of a more rare, and they just were not seen even despite the high IRT. And then there were 4 individuals where there was that second mutation was not identified in the sequencing. Some of those cases were gross duplications and deletions. Just to highlight a little bit more about California, I borrowed this slide from the Department of Health. I wanted to point out of the 500,000 live births, half of them were Hispanic, 257,000, where the other half, being non-Hispanic, were quite diverse. Dr. Boo provided me this slide. It's from the CF registry, but it really illustrates a changing epidemiology in cystic fibrosis, where the number of Hispanic patients with cystic fibrosis is increasing and continues to grow in California. Taking a closer look at the California group at our center at Stanford, the adult program has only 6 Hispanic patients identified by our Port CF registry, where the pediatric program has 56 Hispanic patients identified. With regards to how to care for infants identified with cystic fibrosis, the newborn screening program, there were guidelines published in 2009. They were put together by the CFF, and they were published in the Journal of Peds. And what they did is they went through and looked at the evidence out there and how to provide care for these individuals. They looked at 55 primary studies addressing some of these, what to do, what to say. The recommendations are for an infant identified through the program, they should be seen within 24 to 72 hours. We should provide monthly visits for these infants for the first 6 months of life. At that initial visit, we should confirm the diagnosis, provide some basic genetic counseling, and really convey the difficulty of prognosis with intervention, review some of the overriding signs and symptoms of CF so the families know what to look for and when to alert their pediatrician. Try to introduce them to our cystic fibrosis care team, although in my experience, sometimes that can be a little overwhelming to meet all those people in one visit. Provide the family with resources of information. You know, we're not the only CF center in the Bay Area, so also let them know there are other places they may provide care, and provide them with contact and follow-up information. Doing all of this while trying to be very sensitive to the shock of this newborn screen and them coming to the center not thinking that there was anything unusual about the birth of their child. With this initial visit, I have a colleague that worked at the newborn screening program in Madison, Wisconsin. Her name is Audrey Plezak, and she has built her career on how to break the news to families about the diagnosis. And one of the things I distinctly remember her talking about is what families appreciate. And what they appreciate is what you know and what you don't know. They prefer honesty. So if there's something that you don't know, if there's indecision, they'd rather know that than being left with half answers. It's important to provide the education and support services that meet our families' needs. Some families are not able to understand very complicated genetics, so we have to tailor our information per individual family needs as well as language. We work immediately to establish care and coordination with a primary care provider. We, with the state of California, do recognize the need for supplemental salt. So we do supplement all infants through the program with 1/8 teaspoon of salt that is divided throughout the day in their feeds. We want the ultimate goal to be at the 50th percentile weight for length for infants that are identified with classic CF through the newborn screening programs. The nutritional recommendations from this working group recognize the dramatic metabolic need. I mean, healthy babies double their birth weight by 4 months and triple it by a year. Babies that are malabsorbing or pancreatic insufficient will have increased caloric needs. So all of our practices are really quick to initiate more calorically dense feeds. The CFF at this time is recommending breast milk or standard formulas, no special formulas, although we will increase the caloric density of breast milk if needed. We're also recognizing the need for fat-soluble vitamin supplements as well as the salt that I previously mentioned. With regards to pancreatic insufficiency, not all babies will present with pancreatic insufficiency at the time that we see them for the first visit. 92% may not present until 12 months of age. We are starting pancreatic enzyme replacement therapy when we see individuals where they have 2 CF mutations that are known to be disease-causing that are associated with pancreatic insufficiency. For those other individuals, we'll wait for laboratory results or the clinical symptoms. With regarding pulmonary recommendations on infants, we immediately follow infection control. We do see our newborns, as most CF centers see their newborns in a separate clinic that's not cohorted with older children or school-age children. We talk to the families right away about smoke-free environment. We initiate airway clearance, not always at the first visit. Usually it's by visit 2 or 3. We obtain a baseline chest x-ray sometime within the first or second visit. We talk about immunization. All influenza vaccines should be provided to infants 6 months of age or older, as well as household members. We also look at microbiology. We try to do a culture right away so we know what is colonized with the baby, and then quarterly or more frequently if indicated by symptoms. We're not using prophylactic oral antibiotics in infants that are healthy without symptoms. With regards to looking at significant early disease, the CFF and the working group is not recommending CT scans in infants unless they have significant lung disease or are not responding to traditional or standard treatment. This care grid here is more to just illustrate all the bases that we need to cover with the infants identified through newborn screening over the first 2 years of life. And it looks at the multi-system and multidisciplinary care network that is part of caring for these children. So, I am moving to one of my next objectives, which is a little bit more of a difficult topic. In July of 2007, the CFF working group worked on creating guidelines for infants that had sweat tests that were not clearly in the diagnostic range, but maybe had 2 mutations or mutation variant. The label that has been set for this is cystic fibrosis-related metabolic syndrome. So really, what is it? It's a high IRT on the newborn screen. It's a sweat chloride less than 60, and up to 2 CF mutations. At least one is disease-causing, but one may not be categorized as disease-causing. It may be, in the literature, defined as unknown clinical significance or variable clinical significance. But also key with this diagnosis is there's no multi-organ system symptoms of cystic fibrosis. This diagnosis does not imply the infant has CF, but in some patients, signs and symptoms may ultimately lead to the development of classic CF and the diagnosis of CF. The consensus regarding CRMS is each infant is an individual, and each case is uniquely different. The phenotype, how that infant is when you see them in the clinic room, how their illness progresses over time is more important than what the genotype is. We, as well as the CFF, recommend the genetic counselor discussion with these families. Not all of our families will seek formal genetic counseling with a genetic counselor in a separate session. That's something that we're working really hard to get families to do. We work with the primary care to concurrently provide care because they'll be starting to see these infants for intercurrent illnesses. An average child can get 7 colds a year. How much do you know is regular childhood illness versus something that may be CF related? We talk to the primary care provider about notifying and coming back to us if we have an infant that's not gaining weight, that has loose stools, excessive gas, abdominal pain, or respiratory symptoms that last for longer than 2 weeks. Most infants with CRMS will be initially very healthy. The males have a higher risk of infertility. These infants, despite maybe being asymptomatic at this time, will still benefit from new treatments and drug development. We are providing updated information to the families as become available. One example may be with CFTR2. There have been mutations that have been changing definitions and classifications, and infants that have been identified through that program are being notified and counseled. The consensus still is in this group, if these infants are growing Pseudomonas aeruginosa, that they should be treated. We are repeating a sweat chloride at 6 months of age. Again, these are symptom-free infants. They should have at least twice yearly visits during the first year and then once yearly. If they begin to develop symptoms, they need to be seen more frequently. We should do a culture with visits, x-rays if they're symptomatic, spirometry when they're old enough, a smoke-free environment, and influenza vaccines. There's still no consensus with this group on whether or not we should provide salt supplementation, but we do know that if we measure the salt in these infants that have intermediate sweat chlorides, their salt amount is still 3 times greater than an average. So we are supplementing with salt at our center. The central difficulty in defining these guidelines are clinicians hesitate to apply a label to an infant that's symptom-free, but others have the thought of why miss an opportunity to provide preventative care. So with each family, with each infant, we need to weigh the benefit of preventative care with the burden of treatment. So I have included 2 slides to address CRMS and aging. So a CRMS person that's older may present as an older adult with a sweat chloride less than 60. You may see them in an adult pulmonary clinic that have a diagnosis of atypical CF or non-classical CF or CFTR-related disorders or a low-risk genotype or mild variant CF. Sometimes we'll see adults who will present in these adult clinics because now they're coming for a diagnostic evaluation because they do have classic multi-system disorders. What do they look like? Well, they could look like this guy right here who, hikes and bikes and maybe has male infertility, maybe intermittent pancreatitis. They could not have any symptoms at all. They may have severe lung disease and severe clubbing. So the range of physical presentation can be quite great. At Stanford, we have embarked upon a project. Back about 5 years ago, I worked on writing a grant to the CFF to look at sweat chloride. And what we wanted to do was look at the longitudinal values of sweat chloride among these infants identified through the newborn screening program. So I want to speak a little bit about this project that's part of the newborn screening program. It became a multi-center site, so there are a number of CF centers in the state of California that have contributed patients to this study. The study objectives were to evaluate the longitudinal sweat chloride results among infants identified by the CF newborn screen program in California. We looked at including CF infants that had 2 mutations identified on the newborn screen. We did not take premature infants, and we didn't take micropreemie babies in this study. We excluded infants that had NICU stays, that had requirements of IV fluids or IV nutrition, or had some other medical problem that may cloud some of our data. The guidelines were in place right now, separate from the study, do call for the salt supplementation. So these infants were receiving the salt supplementation. And with the infants in the study, we categorized the CF mutations by class. We did obtain informed consent. The study participation occurred during our routine CF center visits, and it was over a 2-year period of time. The salt was provided to the families that did not have it at home. With regards to the CFTR mutations by functional class, this will be important in another slide. For infants that had class 1, 2, or 3 mutations, those are more severe mutations, more classic CFTR mutations, we classified those infants in group A. For infants with indeterminate or maybe perhaps undescribed, they were group B. And for group C, those were the infants that did not have CFTR mutations that were classified. Not surprising, our combination was that we had most patients in the group right here, which is AB, that had 1 severe mutation and 1 mutation that was less severe. In our study, we had a good representation with 36% Hispanic, and we did have a Spanish consent, and 57% were still classified as white. This flow chart is from our colleague Patrick Sassone, who's worked on CFTR2. And in our study, we did have 7 patients with the non-classic CF variants, and then 5 individuals were enrolled that had a mutation that was identified now by CFTR2 as perhaps non-disease causing. At this time, we have 44 infants enrolled, 23 male, 21 female. Their mean IRT was elevated above 100. It was 112. Only 13 infants, 30%, had an initial sweat chloride greater than 60. So that's not very many. 31 or 70% had a sweat chloride less than 60. And by CFTR genotype, we did not have very many with 2 severe mutations. And with the 2 severe mutations, not surprising, their sweat chlorides were of higher values. Some of the preliminary impressions we have from this group of infants in the study is that the CFTR mutation class and sweat chloride values are correlated. There are no definitive trends in sweat chloride values over time. We are continuing longitudinal follow-up. We do have serum banked that we'll be looking at biomarkers in the future. With regards to this slide, this is just to recognize all the families and the parents that have contributed to newborn screening, but also my study. I have a couple slides here of references that provide excellent reading material, but have provided the evidence for our practice as well as the recommendations that we are giving to the CF community. I wanted to close my talk because I'm originally from Minnesota. So Charles Mayo of the Mayo Clinic said the prevention of disease today is one of the most important factors in line of human endeavor. And now I can take time for questions or discussion. I welcome them all.
We have lots of time.
We do? Okay.
Excellent.
I'm gonna push that.
Could I be the first?
Mm-hmm.
Okay, so you mentioned, microphone? Oh, thank you.
I don't need a microphone, but I'll use it.
You mentioned the parents who, the child has one gene.
Mm-hmm.
Well, that means the parents have
Right.
carry, or one of them has CF. It's possible, right?
So what we do
Uh-huh.
is if we have an infant that comes to our clinic, they have two CF mutations or a CF mutation and a variant identified, and their sweat chloride is not in the diagnostic range, what we will do is we will obtain blood on the mother. And that will further help establish that they received one mutation from mom, one mutation from dad. Occasionally, not often, but occasionally you'll find an infant that will come through the system, through the newborn screening program, that will have two mutations identified, but they came from one parent, but they're on just one chromosome. So that parent is just a carrier with one healthy gene and then a gene that has two CFTR mutations. They're called complex alleles, and there are some described in the literature. And we will get some at our center. So for those infants that do not have a clearly diagnostic sweat chloride, we do check. And it's also a way to double check for the parents, that, yes, we always know mom's mom, so mom has this mutation by default, dad will have the other.
And one more follow-up question to
Yeah.
that. Are there any discoveries that a parent might have CF?
Not
Not
at my site, but I can't speak to other sites.
So I have, I could ask many questions. There's a lot of interesting stuff there. The one that really intrigues me is you had a slide on, I think you called them the misses or the negatives. What was your?
The missed cases
Missed
by the newborn
cases.
screening program.
So could you kind of give a few more highlights speaking to, okay, how do you find the ones you missed? Do they turn up clinically or whatever? And then what's your speculation based on the misses as to how many that you miss that you're not even detecting? I was kind of surprised at those numbers, but I couldn't do the math in my head fast enough to figure out what the percentages are. Maybe you could tell us percentages, how are they showing up, and how many do you think you're really, really missing?
I don't think we're missing very many. The 33 that were missed by the newborn screening,
Out of 448?
right. The ones that did not have an elevated IRT, I can speak to a couple because I know the cases pointedly. I can't speak to all of them. A lot of those infants were symptomatic already, so they wouldn't have gotten missed. They were in a neonatal intensive care unit. In babies that are born with meconium ileus, sometimes they do not have a high IRT, and so they would be missed. But fortunately, our neonatologists know very well for babies that have meconium ileus, that the suspicion is high that they will continue to work up the baby. So some of those cases were, meconium ileus babies. The children that did not have a 40 panel, they were mutations that were more rare. I don't have any of those at my site, so I can't really speak to how clinically they were doing. There are some individuals that will have a severe mutation and then one that is not picked up by sequencing. Those individuals have gross duplications or deletions. Those children are usually quite sick and have sweat chlorides that are positive and are also picked up clinically. Because again, remember, this is screening, that's not diagnosis, and so anytime you have a suspicion of a baby that has a negative screen but you're still worried about CF, you work the baby up.
Hi, I just wondered if you can explain why patients that are born with meconium ileus don't have a high IRT.
We don't know. We don't know. But they don't always, you would think, because it's a stressful delivery, but the IRT is not always elevated in some of those babies. We actually had a couple at our site that did not have an elevated IRT.
And then my second question is, I think probably there's a lot of pediatricians in the greater California area who really depend on newborn screening to catch kids with CF and might not know to check if they start to see symptoms.
We do get referrals that their newborn screen was negative and they may have a child that's failing to thrive or recurrent respiratory illnesses, and they will order a sweat chloride. If the sweat chloride comes back negative or below the diagnostic range, it doesn't necessarily mean that there isn't CF there. I think that those children should have a thorough evaluation through pulmonary at a CF site if suspicion is high for CF, because it's not all about what the sweat chloride value is. We do have pediatricians that call. They do ask for advice. They also call and have questions about the newborn screening algorithm. It's a little complicated. Sometimes they have lots of questions when there'll be one CFTR mutation identified, so they're a carrier, but they're not clear that it's a carrier, and how do you explain that to a family? We do have genetic counselors available on the phone that can do that, but we still have referrals for evaluation for CF despite newborn screening.
I'll ask another question if no one else is going to. Are there going to be patients that are considered to have CRMS that will eventually be changed to a diagnosis of CF?
Yes. I mean, and that's a consensus of the group. The California Newborn Screening Consortium is currently actually working on putting out some formal consensus statements, but just because someone is given the diagnosis of CRMS does not mean that that diagnosis can't change in the future if that person develops more multi-system. So diagnoses can change. They're not carved in stone.
We have a question from online.
Okay.
Do you know how CFF is addressing drug therapies like Kalydeco for the non-classic CF?
We're recognizing that those individuals may still develop disease in the future, more pronounced disease in the future. We also recognize that they do have some altered CFTR function. We do recognize that those individuals still may benefit by some of those pharmaceutical therapies. What is difficult to know is what outcome measures are we going to use when we use those drugs in those individuals that are, at this point, healthy with normal values, normal spirometry. it's also, again, a question too on the infants. What outcome measures will you use to evaluate the effectiveness of those medications?
What happens when a family has a child diagnosed with or categorized as CRMS from the insurance standpoint? Do they cover it? Do they not cover it? What happens to
Well, there is an ICD-9 code. I mean, it is a recognized diagnosis that should be covered and reimbursed. In California, with the newborn screening program, CCS is helping support coverage for care of these infants, whether it's CRMS or CF through the newborn screening program, if there is not a secondary insurance.
Would you describe the state of things in California after 5 years in terms of how many sites? Does everybody think this is absolutely the best thing that's happened in the last century?
It has provided early intervention for a large number of infants. It has provided also a lot of questions. I think that with regarding the diagnosis of CRMS and trying to balance how much to intervene with this patient population is difficult. California also has a population that tends to move around quite a bit, as well as, insurances change after the first of the year. So one of the things that I do see is as families move around, it's not harder, but it's more effort to keep track of people, because you do want to follow these infants over time. You don't want them to get lost to follow-up. You don't want them to show up in 5 or 10 years with respiratory issues or nutritional issues because they were lost. We do have a tracking mechanism in place, but people do move.
One of the questions I have is that, being from the old age, I remember when patients were finally diagnosed, often they had a lot of symptoms, and the families were thankful that they finally understood what was going on and had a way to treat it. And now with newborn screening, a lot of times we're telling people who are bringing in healthy infants that their infants are sick. And I'm not sure they're buying into that whole idea. Can you speak to that?
I think that the individuals that have babies that have sweat chlorides that are not in the diagnostic range, trying to explain the laboratory test, try to explain what we're looking for, those families are more difficult to communicate the need for follow-up because they have a healthy baby and their baby should be healthy. As we become more experienced with the infants that have the one mild mutation and the one classic mutation, we have more experience to know how these babies will do over time. So there's a little bit more comfort, I think, in the clinician standpoint. But from the families, they're shocked. And it's a very complicated thing to explain to a family what this means. They're very appreciative. What I try to always do is tell families, what you have. You have a very healthy baby that's doing well, and it's our job to watch and make sure that continues. And when it's put that way, they're more interested in follow-up for surveillance. With regards to treatment, what I've seen, they're less likely to want to do preventative therapy, but if there's an illness, they are really seeking attention immediately, and their concern is elevated. For the infants with positive laboratory tests, classic symptoms, those families are more than willing to do any intervention right away because their baby's symptomatic.
One question online.
This is a question from one of our online audience members. If you have a child with a genotype of one severe mutation and one more rare less severe, being that CF is an autosomal recessive disorder, Does the more severe mutation mask the lesser, or might there be some blending inheritance?
There's no rules. There's no rules, but often the more mild mutation will take precedence, so the child will be more healthy. There are so many things out there that we can't control, we can't test for, gene modifiers, environment. But generally, when you have a more severe with a mild, the phenotype or how the child presents is that of the more mild mutation. Not always, but
What's your standard operating procedure to preventing misdiagnosis? Before you tell a family that they have cystic fibrosis or they're in that category, I mean, because that can be pretty devastating information. What do you do to avoid that, or your center?
well, we do have a systems of double checks in place. The state of California does track from where they get the blood spots and how it's tracked through the system to make sure there aren't mixed up blood in the lab. There's a process in place for that. At the CF Center site, a way to also provide that double check for the family that these laboratory results belong to your child is obtaining the blood on the mom. We will perform for the individuals that don't have a diagnostic sweat chloride. We do repeat the sweat chloride. We have had a couple families that have wanted second opinions, and so they may go to another CF center that's recognized in California, or they may have laboratory studies done for their genetics and run commercially at a lab, and they've done that as a way to sort of double check. It doesn't happen very often, but we have had that also occur. But we don't have people that have a positive sweat chloride and 2 severe mutations and are told they have CF, and then we change the diagnosis. That hasn't occurred.
How expensive can gene mutation or
Oh, the testing?
the testing, if a family had to pay out of pocket?
If you look at specific mutations that are tested, it can be, for example, if you know gene A and gene B run in the family and you just want to look for those 2, it can be under $1,000. If you're looking for full sequencing, it can be more. But generally, it's just a couple $100s per gene if you're just looking at 2 genes. So it's more affordable. And again, for the infants that don't have a sweat chloride in the diagnostic positive range, and we are concerned, the newborn screening program through the state will pay to check moms to make sure they came on from separate parents.
Talk about the 50% Hispanic birth rate. The program is looking for 50 different diseases. CF is only one.
Right.
Right?
Right.
How are the Hispanic population doing with this?
Pretty well. I mean, they've recognized. I mean, CF is recognized in the Hispanic community, as well as the other ethnic groups, although not as with increased frequency. All of our educational materials are also in Spanish. For those that are not able to read, we have videos. For the infants, I always use an interpreter in person, not over the phone, because so much is conveyed in a clinical setting in person and with demonstration for all of our infants. Just the complexity of it is so great that we do have an in-person interpreter for each visit, which is very helpful. I don't see any differences in follow-up and compliance. It's the same.
staying on that topic, just because it seems like for so many years, CF was really identified as really more a disease that impacted people of European descent. So have people been surprised by, I mean, I know California is a very diverse state compared to others, but in California, have people been surprised by the large number of Hispanic patients? And tagging on to that question, isn't there quite often a more severe disease expression with that population based on the genotype, or was that wrong?
With regards to disease severity, I can't always say disease is just as severe or more severe, because for every child that is of Hispanic, you can find a counterpart of a European descent with severe disease. I look at some of the infants that are identified through the newborn screening program, and regardless of ethnicity, still there are differences in children that have the same genotypes, and had the benefit of newborn screening, but still, why is one patient failing to thrive? Why does one patient have more severe lung disease? There are still so many subtle differences with gene modifiers and environment that we can't always explain the differences, even in family groups. And we're seeing that too, even in children. We've had some families that have had infants that are identified through the newborn screening program, and who have older siblings that were born outside that do get subsequently diagnosed. And just looking at the range within the same family is remarkable.
So, a couple interesting thoughts here. There must have been a thought or a projection when the screening program was started as to how many infants would be picked up based on some frequency data that we had from the past, what was the frequency of incidence. But I think we were all told way back then that it depended on ethnic groups and things, so those be hard to predict. So I'm curious what you actually found versus what might have been predicted, if there was such a prediction. And I'm curious about, maybe prediction's too strong of a word, but based on 5 years worth of experience, do you think in 10 years or 20 years we're going to see a change in the lifespan of somebody with CF because of this, or do you think it's too small of an effect? What do you think about those things?
Well, with regards to the program with the newborn screening, prior to the implementation, this was prior to when I came here, there were some population-based studies of in California looking particularly at the population and the incidence of CF. And so the panel that was developed for screening was pointedly developed based on what was studied in the population prior to newborn screening. The Department of Health looked at and included pointedly mutations that were identified in the literature associated with Hispanic populations. And as the screening progressed, those other mutations that were added to the 40 panel were seen in the population with more frequency. So that's why the panel is as it is, because of the diversity. And it was pointedly made that way because of our population in California. With regards to the life expectancy, yes, I firmly believe that we will see infants that are identified in these programs in 20 and 30 years not having as severe life-limiting complications as, I saw 25 years ago before newborn screening. I have even seen that in my career as a nurse practitioner when I started out. For example, I know that we talked about transplant. Well, back in my days, we were transplanting people with cystic fibrosis in the teenage years or late teens. Rarely do we see children with CF needing transplants at 8, 9 years of age. So that's just a function of something, again, over time. It happens, but it's not, the population is changing. Well, thank you.
This was really a wonderful and very informative presentation tonight, and I know we all appreciated it very, very much. I learned a lot. I'm sure you all learned a lot, and I think there are so many more questions that will come out of this discussion. So I don't know, is there a way for interested parties to reach you, or should they come through us to get to you, perhaps?
You can always email me.
Okay. We'll.
You can put it up. Sure.
Okay, well, if people are interested, and those of you online, you can get a hold of Jackie through us at CFRI, at cfri.org, and we will get the questions to you. But I think that this raises a lot of interesting what-ifs, and where are we going, and we know where we've been, and now where are we headed. So there's a lot to be done, and I think that having the newborn screening provides a lot of hope for those infants that are later diagnosed with CF. And so for that, I know that we're all very, very thankful. So thank you, Jackie, for joining us. And just a few more little of those housekeeping duties. I want to thank Caesar and Marissa again, Genentech, CF Services Pharmacy, and Cornerstone Therapeutics for sponsoring tonight's event. Again, we can't do this without them, and it makes a big difference so that we can provide more services to our community. So thank you very much. The next CF Discovery Series will be held on March 11th. So we hope that you will return, either in person or online. And if you could, please fill out those very important evaluation forms, because we do take a look at them so that we can determine what it is you are interested in hearing about, and how we're doing, and how we can improve. So thank you very much. We appreciate you coming tonight. Have something more to eat. And again, Jackie, Zirbes, thank you very, very much.